So
Right. So the topic for today is nebulized heparin for patients with or at risk of ARDS. And this study was conducted in Australia. It was a multi-centered, randomized, double-blind, placebo-controlled phase 3 trial. So, so the clinical question they had was, patients at risk with ARDS, can they be nebulized by heparin compared to placebo? Will that accelerate the recovery of the physical function? That was assessed 26 and 60 days later. So ARDS affects 23% of mechanically ventilated, and it has a mortality rate of 46%. So the survivors of prolonged ventilation, and they have who develop ARDS, they have marked the physical function even later, which prolongs, and they are often seen to be readmitted to the hospital, and their rehab services and other long-term care, they require more than the others. So the pathophysiology of ARDS, it includes mostly fibrin deposition, basically, and it has an inflammation-induced pulmonary fibrin deposition, which leads to thrombosis of the microvasculature, and that causes that's actually in relation to the acute lung injury as much as the fibrin and deposition. That's more. So heparin, they use that. So the thing was that with heparin, they could mitigate the fibrin deposition, and in phase 1 and 2 trial to see that there were improvement in the pulmonary dead space and coagulation activity and microvascular thrombosis. And heparin has other benefits like binding to the bacterial and viral pathogens, inhibition of the inflammatory pathways, and reduce the mucositonicity and prevent bronchospasm. So the study was designed with multi-centered, double-blind, as I already mentioned. So randomization was done in 1:1 ratio. One group was given nebulized heparin, and the other group was given normal saline. The primary outcome was that was assessed was physical function score at 60 days, and secondary outcomes were development of ARDS and at risk at day 5 and mortality rate at day 60 and later. So the setting was 256 patients were recruited, and 9 hospitals in Australia had this, and the data was collected from September 2012 to August 2018.
yeah, but it's a little bit interesting to actually, in terms of its validity externally, 50% of those patients were all from one centre, and they actually found 2,036 patients that would have been appropriate from their initial screen, and they managed to exclude nearly all of them. Actually, 86 of them were excluded clinician objection, which would represent about a third of the patients they actually used, which I thought was a bit interesting. Go on to let's talk about the inclusion criteria.
So the inclusion criteria included all of the following: mechanically ventilated patients, they were more than 18 years, and who needed mechanical ventilation on the day or day before the recruitment, and who expected to require invasive ventilation until the end of the next day. And the PF ratio was less than 300 and or SpO2 FiO2 ratio of 315 at any time since commencing the invasive ventilation. And active ventilator circuit humidification was done. Exclusion criteria.
There's lots of these. So essentially any allergy to heparin or history of HIP, which seems quite sensible, and similarly low platelet count or APT over 80, which would also exclude heparin use. And then essentially any history of any kind of bleeding pretty much excluded you. If you had a pre-existing tracheostomy, oxygen or assisted ventilation at home, of which there weren't actually many patients on the list. If they had a neurological diagnosis impacting on respiratory function, if there were other treatment limitations, meaning they wouldn't be eligible for RRT or vasoactive medications, if they had dementia or they were considered imminently dying, or if they were pregnant. And so they actually managed to, and then the standard exclusion criteria, patient refusal, clinician objection were in that list as well. So actually, of the patients that they did eventually go through and match, they did match okay. So age was well matched, age, sex, presence of other respiratory diseases, so COPD, asthma. Although it's quite a heterogeneous sample, really, and the actual range of that's quite broad given the inclusion criteria they had before. And similarly, the risk factors for ARDS were relatively well matched across the groups. So pneumonia was the number one diagnosis, with non-pulmonary sepsis being the most common, aspiration injury the third, and there were some other ones that were less likely down the list, things like cardiopulmonary bypass. And their Apache score was fairly well matched. It was an intention to treat analysis, so once they were on that pathway, they were kept on that pathway for analysis point of view. Relatively well matched for therapies again. Most of them were on vasopressors at some point. Similar percentage on renal replacement, steroids, and similar instances of all of the standard respiratory rescue therapies, with nothing too exciting in there really. And similarly, their lung injury assessments were very similar. So it was slightly more at risk of ARDS in the control group versus slightly more present in the intervention group. Actually, the severity was similar throughout, and the Murray lung injury score was quite similar. In terms of the actual intervention, it's fairly straightforward. So it was either 25,000 units in 5 mils nebulized QDS for 10 days while they were ventilated, or a control. And they were both kept on the normal standard of care, which included systemic heparin, whether that's subcutaneous, low molecular weight, or heparin infusion. And this is where it got a little bit interesting. So actually, their primary outcome was a null, and they didn't find any significant difference in the functional score at day 60. And that's just taking the raw scores. They lost about 10% to follow-up, which isn't fantastic given their power already. What they did notice afterwards, interestingly, is that you can see on the violin plot, there was actually suggestion that the intervention group had less patients ending up in the lower, a little bit of the SF36 score. So the lower the score, the worse your physical function is. So they did notice that, accounting for it, it does appear to be a lower proportion of the interventional group in the very poor physical function at day 60. And you can see those mark the second standard deviation, that there's quite a much tighter grouping around the middle ground in heparin compared to the placebo. I've lost my secondary outcomes, there they are. So what's probably more interesting is the secondary outcomes. So they didn't find any significant difference in adverse events. So the rate of transfusions in particular was the same. I think there was one episode of hemoptysis in the intervention, but nothing overly major. Mortality was relatively similar. The problem is, because they didn't aim for these secondary outcomes, none of them are corrected. So they're all typical type 1 bias and type 1 error. But they did find that significantly there were fewer cases of ARDS developed from the patients that were in the at-risk group. There was less of a deterioration in the Murray lung injury score. There appeared to be a faster recovery, if only by one or 1.5 days. And similarly, I think there was a 1.5 day average time to separation from ITU. So they were on ITU for 1.5 days less. And there appeared to be, in terms of residents, more of the survivors in the intervention group were actually at home rather than still in hospital at day 60. And there's a marginally small, the actual overall readmission rate was very small, but there was significantly less in the intervention group in comparison. So actually, they didn't show any improvement in primary outcome, but then I suppose the big question is, did they just choose the wrong outcome? And is actually physical kind of function score at day 60 really what we want to know from the end of the study? Or is something more like mortality, ventilator-free days a bit more relevant? Certainly the secondary outcome measures would be consistent with their phase 2 trials that they used to kind of get the idea for the study in the first place. It's nice that the safety data is pretty comparable. So there didn't seem to be any real problems with administration of the nebulized heparin. I believe they had 2 cases of kind of transient rise in airway pressure during nebulization, which doesn't seem too bad really for the whole thing. And it did seem to be tolerated quite well with the systemic heparin. There's a slight increase in peak APCT, but nothing overly dangerous. But actually, on the basis of this, there's still no real strong evidence for nebulized heparin for treatment or prevention of ARDS, although it does raise the question for actually more studies would be a bit more useful in the future, probably with more controlled groups, so it's not everyone that would possibly be at risk with an PF ratio less than 300. We didn't know if anyone had any questions.
Have you unmuted?
I've unmuted.
You have unmuted. Excellent.
Sorry, I got a phone call during the majority of that.
Sure.
So what was the primary outcome? Like, just in quick summary.
So the primary outcome was it's something called the SF36. So it's a functional score.
Interesting.
So it's developing their kind of baseline, their physical function at the end of it. So a higher score, more function. Essentially, I believe it's 0 to 100. So whether it's actually that helpful of day 60 for functional score and really what we're looking for, I'm not sure.
Yeah, I think it suffers from the same as all these ARDS studies of very small numbers in enrolment, and you don't therefore get a particularly useful outcome. I guess what would have been helpful again is if, and they always say this with all ARDS studies, if you have some sort of biomarker to be able to establish which patient group might benefit the most, that would be useful. So if you're able to determine which patients have got more microvascular thrombosis than others, for example, something like that, that would be very useful. So perhaps if you tied it in with D-dimers as a marker of diffuse clotting, then you might find that if you separated out and studied those patients, they would show a greater benefit conceivably. And that's potentially an avenue they could take in future studies. It's certainly something that's not really been adopted sort of globally, this sort of nebulized heparin yet. And as you rightly point out, there just isn't the evidence yet for it. There is evidence that it's not harmful, but there's not really any evidence that it's beneficial. What is interesting is obviously there's a disease state going on at the minute that would seem tailor-made for this sort of treatment. Now, they have...
Yeah, they mentioned it specifically in their paper, I think, given that it would be a really interesting one, since it seems to be more of the case compared to previous ARDSs.
Indeed, and I think it'd be very useful to know, does it help in COVID? Because obviously you've got a viral illness and it is proposed to be an antiviral agent. It's a disease where you get a lot of mucus secretion, and that's a real problem, and it's proposed to be a mucolytic. It's anticoagulant, and obviously thrombus is a huge element of in COVID, and it's this anti-inflammatory property, and that's thought again to be a big element of the disease process in COVID. They are doing a study looking at heparin nebulization for COVID, but again, it's not going to be a big study, and I think it's a real shame, a missed opportunity, because if you did it early in COVID, you could get thousands and thousands of patients enrolled into a study like this and get some really meaningful results. But ultimately, the end of it, we'll then know, does it work or not work for COVID? We don't know whether or not it works for ARDS in the future. So there's sort of 2 questions there. Is one, should we be using this in COVID? Maybe, and we'll wait to see what this smallish study says. But then there is still the future question, say if we ever get through the other side of this, then how do we treat our normal ARDS patients? And we need a separate study to look at that really, which would be very helpful.
Did they say why they lost 10%?
They
follow up 10%.
They did. Bear with me. I've got it.
Oh, no, fine. No, I was just curious. That seemed like quite a lot.
No, they did. There was a few. Let me just get it up. Yeah, because like reading the actual not enrolled was interesting. Yeah, so a few of them that they lost. So I was going to say the other issue that they lost is you can't assess the dead patients. So because it's a functional outcome score, if they're dead, they obviously have no functional capacity. So they lost a number that way as well. That I forgot to mention. So yeah, they actually only ended up with 97 and 94 assessed. So it's actually only 200 really.
I mean,
They haven't really said why they lost them on there. I'm sure I could dig in and find it.
I know. Is it, so what we're saying, potentially 10% was largely mortality. I mean, that could be the case, right? I mean, you
No, it was separate. The 10% was separate.
okay.
Fine. Because you could argue if you're dead, your functional status is pretty poor.
Yeah.
So
yeah, well, that's it. That's it. So they're not included.
I'll ignore that.
No, exactly. They're not included in the final outcome.
That's not.
And was the mortality equal across both?
I believe yes. I believe so. Pretty similar.
Yeah.
Fine.
23 in the heparin, 18 in the non, and then they lost 12 in the control and 8 in the conventional group. So actually you had 97 in the heparin and 94 in the nebulized saline. What did happen is they lost a few to few of them were transferred to other hospitals.
Cool.